Hello, I'm Dr. Roger McIntyre, Professor of Psychiatry and Pharmacology at the University of Toronto and head of the Mood Disorder Psychopharmacology Unit at the University Health Network at the University of Toronto. At the APA in San Francisco, we presented some very new data as it relates to the mixed specifier. What is the mixed specifier? Well, let's begin with mixed states. Clinicians are very familiar with the older definition of mixed states that appeared in DSM-4. Mixed states were defined as the co-occurrence of syndromal mania and depression. One of the limitations of that definition is that it was not commonly encountered in clinical practice. Most patients we see in clinical practice have syndromal mania with so-called subsyndromal depressive symptoms, or conversely, have syndromal depression with subsyndromal hypomania. The DSM-5, I think, was very wise in putting forth this new notion of mixed specifier, which generally has been defined as 3 or more opposite polarity symptoms during a manic, hypomanic, or depressive episode. So in other words, if a patient has a manic episode and has 3 or more depressive symptoms, they would fulfill criteria for the mixed specifier. Again, conversely, syndromal depression, 3 or more manic symptoms, they would have depression with mixed specifier. During the APA this year, I presented some very preliminary data indicating that some of the atypical antipsychotic agents may in fact have differential efficacy. That is, they may have a superior effect over others in mitigating either manic or depressive symptoms in patients with mania and depression, respectively, with mixed specifier. I showed some data that suggested that in patients who have mania, treated with aripiprazole, if the patient in fact also has mixed specifier, aripiprazole may be superior in efficacy to another well-established antimanic, that being haloperidol. I also showed data for asenapine, another well-established antimanic, that when these individuals meet criteria for mixed specifier, asenapine not only is superior to placebo, but may have an advantage over olanzapine. On the other side of the pole of bipolar and depression, I followed up with some also new data showing that lurasidone, with replicated evidence in bipolar depression as an adjunctive therapy or as a monotherapy, when we look at patients who have subsyndromal hypomanic symptoms while depressed, lurasidone was as effective in those with the subsyndromal hypomanic features as it was in those who did not. So taken together, what we've learned is that most people with mania or depression have subsyndromal opposite polarity symptoms. The DSM-5 has operationalized that as a mixed specifier, and we're seeing a suggestion, at least from the data I'm showing at the APA, that some of the atypicals may have an advantage over others in mitigating manic symptoms during the mixed specifier, or in the case of lurasidone, mitigating depressed symptoms in patients who have subsyndromal hypomanic features.